Hello, everyone. I'd like to thank the organizer for inviting me to speak today. The topic of my talk is suitability of oral versus intramuscular PrEP in Asian countries. Suitability, as I was assigned giving a talk, is an interesting term. Although we all know when there's a splendid, suitable outfit in front of you, there's always thousands of ideas passing through your brain if you are having trouble making decisions like me. And eventually you might not always buy it. That's why we will talk today. This is the outlines of my talk. We will start with the PrEP status quo in Asia, then move to the clinical evidence of long-acting cabotegravir intramuscular injection, followed by more detailed discussions of challenges and barriers we might encounter while implementing this new preventive tool. The number of people who need PrEP and actually receive PrEP has been constantly and disproportionately low, despite so many years of hard work from all of you listening to the talk. UN set the 2020 goal, which is that 10% of at-risk population should receive PrEP globally. And we were far behind that target. More ambitious targets were proposed, like 50% by UNAIDS or even 90% by local government of New South Wales in Australia, if we want to see zero transmission by 2030. That means we need not only to broaden the coverage of oral PrEP we already have at hand, but also explore the role of long-acting intramuscular PrEP, the new powerful weapon. Back to Asia, it's a huge continent with versatile races and cultures. With the travel restriction to be lifted soon, we have Malaysia, truly Asia, amazing Thailand, incredible India, imagine your Korea, and Taiwan touch your heart, etc. The healthcare systems from each country are very heterogeneous too. So was the status of PrEP implementation. We have countries like Australia with very well-established PrEP services, or Thailand and Vietnam with many innovating delivery models providing PrEP to different key populations, or countries like Malaysia, the Philippines, Japan, Taiwan will mainly try to scale up PrEP coverage at this stage. As we can expect, such a long-acting injectable PrEP product will also play different roles and even have different priorities to implement in each country. Last year, we shared this slide introducing long-acting cabotegravir, or CAB-LA, an integrase inhibitor structurally similar to dolutegravir. Along with long-acting ribavirin, it has been approved as maintenance therapy for people living with HIV, giving intramuscular injections every 2 months. As for PrEP, bi-monthly CAB-LA can be given alone and has been demonstrated superiority over daily oral TDF-FTC in 2 large-scale randomized controlled trials. HPTN-083 recruited more than 4,500 GBMs and transgender women in America, Africa, and Asia. HPTN-084 enrolled more than 3,000 cisgender women in sub-Saharan Africa. Both trials was unblinded early by DSMB due to a good safety profile and apparent superiority in efficacy during interim analysis. Compared to daily oral TDF-FTC, bi-monthly CAB-LA injections reduce 66 to almost 90% of new infections. To be noted, there was a fair proportion of Asian study participants from Thailand and Vietnam in HPTN-083. With the accumulating evidence showing the efficacy and safety of using CAB-LA injection for HIV prevention, Last December, US FDA approved its use for PrEP in at-risk adults and adolescents weighing at least 35 kilograms. And it marked an important milestone as PrEP-LA is the first injectable and long-acting form in PrEP history. The US CDC soon updated their PrEP guidelines, which also includes new recommendations on PrEP-LA and its specific follow-up schedule as shown on the right side of the screen. Also, during last year's talk, we shared this slide, hoping to explain how complex it may be from bridging clinical trial evidence to real-life implementation. For example, PrEP-LA is superior in efficacy for HIV prevention over daily oral TDF/TC doesn't mean they are necessarily preferred by all at-risk populations. Second, PrEP-LA solves some adherence issues in people who have problems taking oral PrEP daily, although there's still its own adherence issue, especially regarding breakthrough infections during the long tail phase after PrEP-LA is discontinued by the users. Third, there are discussions on whether NAT or PCR tests should be included in the routine monitoring schedule to pick up acute infections even earlier. Finally, nothing is more important than bringing the product to the potential user's hand, and its access and price is the key barrier. There are very few studies discussing about the preference or acceptance of PrEP clients and healthcare providers regarding PrEP-LA. It's not an equivalent, but let's take PrEP-LA and Rilpivirine-LA treatment, for example. This is an online survey performed in 4 European countries, Germany, France, Italy, and UK during 2019. 688 people living with HIV on treatment and 120 HIV physicians completed this survey. Of people living with HIV, almost 2/3 were very or highly interested in trying long-acting regimen for HIV treatment, assuming the long-acting regimens were priced similar to current antiretroviral therapy. The majority of the physicians will offer long-acting regimen because of strong unmet medical needs, such as dysphagia, 93%, malabsorption, 92%, interfering gastrointestinal issues, 90%, or central nervous system disorder, 87%. However, more than 80% of healthcare providers consider suboptimal adherence, confidentiality, privacy concerns, and convenience lifestyle also indications for long-acting regimen. However, we all know prevention does not equal treatment. Most of the time, PrEP clients are healthy individuals who don't have swallowing difficulties, malabsorption, or other comorbidities. They might not be on PrEP currently and not have heard about this long-acting PrEP. Even they knew PrEP-LA, it may take some effort for them to adopt this new product. Also, they might stick to the old product they are familiar with and be reluctant to switch to the new product, like switching from Android to iOS systems. Finally, most PrEP clients don't take PrEP for good. They only use PrEP during seasons of risk. So flexible discontinuation and reinitiation of a product could be an important factor for them. For healthcare providers and other lay providers, competence of giving intramuscular injections and proficiency of monitoring side effects will be important. Last but not least is how PrEP can be delivered. Luckily, we don't need cold chain for PrEP, but where, who, and how to give intramuscular jab is still a key question, especially when nowadays decentralizing PrEP delivery is a goal. There are still very few studies on barrier facilitators and preferences to injectable PrEP in Asian countries. Here we have some studies in different at-risk population done in the US. The results are quite heterogeneous, as you can imagine. For example, the first study is from transgender woman focus group in New York City. They compare two proposed long injectable PrEP delivery models, self-injection or injection at drop-in centers. The participants expressed several different factors affecting their preferences over one over the other, such as ability of intramuscular injection by oneself, convenience of access to injection sites, and also very important, privacy and fear of judgment of receiving jab either by oneself or in the injection sites. On the other hand, one online survey from Black women in US showed most respondents actually prefer oral PrEP to long-acting injectable PrEP. And only those who with concerns about healthcare costs or PrEP-related stigma, and those who reported inconsistent condom use and multiple sex partners were more likely to prefer PrEP-LA. Interestingly, in DC, although Black GBSM were least likely to have tried oral PrEP, they share equally high levels of interest in PrEP-LA versus other ethnicities, such as Latino or non-Hispanic white GBSM. Although online survey recruiting GBSM, another online survey recruiting GBSM in the US found similar interesting results. A third of respondents in this study were ethnic minority, that is Latino, 25%, Asian, 12%, Black, 10%, multiracial, 6%, and American Native, 0.3%. Not too surprisingly, almost all GBSM who were not on oral PrEP were aware of oral PrEP, but less than a third were aware of injectable PrEP. As shown by the figure on the left side, interest in injectable PrEP were considerably lower on average than oral PrEP. And there were very, very few respondents reporting low interest in oral PrEP. It expressed high interest in injectable PrEP. It's around 17%. However, slightly more ethnic minority GBSM who were uninterested or neutral for oral PrEP expressed interest in injectable PrEP than white GBSM, which shed light on the potential niche of injectable PrEP in at-risk populations who are aware of oral PrEP but somewhat don't take it. Until we have subgroup analysis data from the Asian trial participants in HPTN-083, as I mentioned previously, we have this phase 1 safety study performed in 47 HIV negative adult Chinese men at low risk of HIV acquisition. Although the sample size is quite small, it's also a rare gem that we finally have a PrEP-LA related study on Chinese population. The PK data in these Chinese male participants were pretty comparable to non-Asian men in historical studies. Interestingly, PrEP-LA as PrEP is highly tolerable and acceptable among these participants. 98% were satisfied with their current treatment to prevent HIV, and 83% consider using cabotegravir-LA for HIV prevention in the future. Still, this is a clinical trial setting with very small number size, and the participants are actually at low risk of acquiring HIV infection, which may be very different from a risk population in real life. In HPTN-083, bi-monthly Cap-A injection were compared to daily oral PrEP among GBSM. However, another oral PrEP dosing schedule or event-driven PrEP is also very common practice among Asian GBSM, especially in Malaysia, Hong Kong, and Taiwan. Our Taiwanese colleague Hui Juan, now studying in Australia, found it's also not uncommon that Taiwanese GBSM clients switch between daily and event-driven PrEP regimen under different circumstances, such as perceived risk at different time periods or whether they have enough pills at hand. People switching from daily to event-driven PrEP are more likely to make mistakes or miss pre-coital doses. Can Cap-A be as flexible or interchangeable as oral PrEP for GBSM? Does Cap-A improve imperfect adherence with event-driven oral PrEP? These are important research gaps, and we need to do more studies to find out. Finally, so far to our knowledge, there are only 4 countries, regions who have authorized Cap-A as part of the treatment regimen for people living with HIV: Australia, Japan, Hong Kong, and Taiwan. Only Australia has launched Cap-A in the market, and they are also planning to file Cap-A for PrEP indication. Although not mandatory for PrEP implementation projects, it is still crucial for some countries to have authorized labeling to administer Cap-A as PrEP, especially when it comes to public or private insurance coverage. Also, for government-run PrEP programs like in Taiwan, only medication with FDA-approved indications can be reimbursed. We rarely heard voices from healthcare providers other than doctors and nurses. As we mentioned, unlike repealing-LA, Cap-A doesn't require cold chain storage. However, in US, such novel treatment is still kind pricey and cause some logistic challenges to the pharmacist. Here are experience from the pharmacists who have participated in Cap-A clinical trials and successfully switched their HIV positive patient to long-acting injectable treatment. Of course, the patients were anticipating exciting, but there are still issues to solve, such as insurance coverage, meeting requirements for patient assistance programs, prior authorization, etc. We don't know yet how Cap-A will be reimbursed by public health insurance in Asia countries, and whether there will be any co-payment from the clients or patient assistance program available from the pharmaceutical companies if the price of Cap-A remain greater than the current first-line oral treatment. Last but not least, we need to talk about generic PrEP. It's not a secret that many people around the world got access to oral PrEP long before brand name TDF-FTC was officially launched as PrEP in their own country. They got it from online suppliers or from local pharmacy clinics doing medical tourism to other countries. This gray market offers generic PrEP with much lower costs. Our colleague, Professor Po Yao, documented such phenomena, like, as he mentioned, Dexter, an empowered Taiwanese gay man who traveled to Bangkok and purchased 40 bottles of 10-OEM, the Thai generic TDF-FTC, to bring back home. While we do recommend our clients to take PrEP under regular medical follow-up, access to affordable generic PrEP is still very crucial for the community, especially in low and middle income countries. So far, we knew there will be no voluntary licensing for Cap-A, so the price issue will be an even greater barrier to all potential users. So this is the take-home messages. Long-acting cabotegravir or CAB-LA intramuscular injection has been shown superior to daily oral TDF-TC as PrEP among GBSM, transgender and cisgender women in clinical trials. Subgroup analysis of Asian participants from Thailand and Vietnam is still pending. Very few countries have CAB-LA, along with long-acting ripivirine approved as HIV treatment in Asia-Pacific region. However, none has approved CAB-LA as PrEP yet. There has been very few implementation projects with CAB-LA, and studies regarding different stakeholders' attitude towards CAB-LA as PrEP have been also scarce, especially in Asia. Whether GBSM will switch from event-driven oral TDF-TC to CAB-LA injection in the real life is unknown. Finally, our other logistic issues such as price and mode of reimbursement in each country remains challenging. Thank you for your listening.